Hello, we are the Association for Child and Adolescent Mental Health, or ACAMH for short.
Good evening. I'm Arnon Bentovim, and I'm chair of the ACEs, Adverse Childhood Experiences Special Interest Group, and it gives me enormous pleasure to introduce Dr. Jon Goldin, our speaker this evening. It's quite extraordinary that a couple of weeks ago, Philip Graham and I gave our presentation about mental health and our views about it, having retired from Great Ormond Street many, many years ago. And you, as one of the folk who followed and followed us at Great Ormond Street, you've now moved into an independent sector, and it's a great pleasure that you can reflect on the work that you did at Great Ormond Street. I know that you were there for over 21 years, and you were a consultant at the Mildred Creek unit, the children's unit that was set up in the name of Dr. Mildred Creek, who was the psychiatrist that that our generation took over from in the 60s, but still her name is there with the inpatient unit, and of course her pioneering work in the field of ASD, autistic disorder, which she pioneered so many years ago. And I know that you were involved with management of the team, and of course the training, together with David Skews, I imagine, with the North London group, and that you've been very much involved with the Royal College of Psychiatrists and have been very interested in communicating in the media. And it's really interesting when I heard about the Schwartz Rounds, which you're going to be presenting. I thought this was a fascinating idea. And I think the whole notion of how we in the health sector manage a compassionate approach to our work with each other and with our families and with the children we're working with is so important. So I think it'll be really interesting to hear your take on the development of this particular approach. I have a very fond memory when I first went to Great Ormond Street, because the professor of child and adolescent health, Professor Otto Wolff, was a great believer in large-scale rounds. So we would all gather round the bed and in the ward, and he would have everybody there. He would have the psychiatrists, he would have the metabolic medicine folk, he would have the hematologists, he would have the whole team. And I think that we learned how important then the whole network around the child was so important if one was really going to really give the best care. And of course, what was extraordinary is when I first went to Great Ormond Street, parents were admitted because when I was a houseman, they were there just on the edge, literally, and then they came into the wards and were part of the whole network. So I think the complexity of care around children where there's a need for hospitalization is so important. So it's going to be very fascinating to hear your presentation, Jon. Just to remind participants that would they put their questions in the Q&A down the bottom, introduce yourself in the chat, which is at the bottom, but please put your questions in the Q&As, and I hope that we'll have some time to really deal with the issues which have arisen. So Jon, please.
Thank you so much, Arnon, for your very kind introduction. And it's nice to hear about the different generations, Mildred Creek, Otto Wolff, yourself, and and Dr. Graham, Philip Graham, and subsequent generations as well. And I think we are very much a community when we work together, and there are generational aspects to it. And within a hospital or a CAMHS team or any particular health service or social service, one works as a community. And I think I'm going to be talking about that today in terms of Schwartz Rounds. I think they very much draw on the community aspect of our work and staff supporting each other. So I'm just going to share my slides, which can you see those, Arnon?
Yes, perfect.
Okay, wonderful. All right, so it's thank you for inviting me, and I'm looking forward to talking about this because this is a topic quite close to my heart. I first heard about Schwartz, and it must have been in about 2012, 2013, and one of the first places that I knew they were taking place at was the Royal Free Hospital, which is not that far from where I live in North London. And I did go along to a Schwartz round there and was very, very impressed by it. And I had been at Great Ormond Street for a number of years by then, but I did, resolve that we should introduce them to Great Ormond Street along with colleagues. One of my child psychiatry colleagues, Rory Conn, was very instrumental in starting them up, and Andrew Long as well, who was a deputy medical director at Great Ormond Street. Very important to have senior people within the organisation supporting Schwartz Rounds, and we were able to gather people who were able to do that. And the chief executive at the time was also able to do that. So that is a very important aspect of Schwartz Round, getting buy-in from the team around you. So I'm going to talk about what is the problem, why do we need Schwartz Rounds, what are they trying to address, what can help, what kind of things can help with sort of the well-being of staff and with challenges that people face who are working within healthcare organisations. I'm going to discuss what are Schwartz Rounds. I'm going to say a little bit about the evidence. This is ACAMH, and I know people are keen on evidence, obviously, and outcomes, and there is some good evidence for their benefit, as well as I sometimes talk about practice-based evidence as well as evidence-based practice. I'm sure many people have heard that before from other people. And, the face validity of Schwartz Rounds is enormous as far as I can see. I see people whenever I do a Schwartz Round or take part in one, I can see people around me benefiting from it and valuing it. But there has been some quite good studies done, have been some quite good studies done by people like Professor Jill Mabon, and I'll talk a little bit about that. I'm going to talk about feedback from the rounds. Obviously, my experience is mainly at Great Ormond Street, and we started the rounds at Great Ormond Street in 2015, and they're still going. I left Gosh less than 2 years ago, but I was leading on them for a few years together with colleagues, and I'm glad to hear that they're still going quite strong, I think. And then I want to talk a little bit about next steps. And if you people who are listening to this talk are thinking about introducing them to your organizations, I can tell you a little bit about how to do that. And I would very much encourage you to do that. Many of you might know about Schwartz Rounds already, but obviously many of you might be hearing about it for the first time as well. So what is the problem? I mean, we work in a very demanding healthcare environment. We're all very familiar with things like the funding constraints within the NHS, the patient population changing. Many patients are older, more frail, more complex. I work within CAMHS, and has worked within CAMHS over the years as well. And young people, their mental health presentations are getting more severe and more complex as the years go by. COVID was obviously a factor in that. But things are generally quite challenging and demanding within the NHS for obvious reasons. There's a high turnover of staff. I think one of the key things to run a successful organisation, especially a huge organisation like the NHS, is to look after your staff. And that's something I've tried to practice what I preach over the years, and been a training programme director and so on. And I've always felt it's very, very important to look after the junior staff, the trainees, the nursing staff on the Mildred Creek unit, all disciplines really. And also to think about within an organisation, how everyone contributes, how the cleaner contributes, the porters contribute, the consultants, the nurses, the managers, etc., etc. Through different levels of the hierarchy, everyone contributes. But we're not always very good at looking after our staff within the NHS and within other organisations. Well, I think the NHS has got a bit of a problem in this area, I've noticed. Obviously, it's better in some places than other places. But the high turnover of staff relates to that. The strikes that there have been in the last few years relate to that as well. I'm glad that they've been largely resolved, but of course there may be future problems in the future, but for now they've been resolved. There's a high level of organisational change and uncertainty. Our current health secretary, Wes Streeting, has talked about the NHS as being a failing organisation. There's a debate about whether that's actually a helpful thing to say or not. Some people say that's, calling a spade and telling it like it is. Other people say that's kind of demoralizing to talk about a failing organization when so much is actually amazing that is achieved in the NHS, and so much work is done that's really, really important and valuable and successful. However, things can improve for sure. And one way to help improve things is to look after the staff better, and Schwartz Rounds links with that. There are many short-term relationships between staff and patients. One of the things I've always liked about CAMHS, Child and Adolescent Mental Health Services, and general practice and other disciplines like that, is that you can, over time, build up a relationship between you as a clinician and your patients. But I think the pressure is on to have short-term relationships, to have quick fixes as far as possible, not to spend too long with your patients, things like that. And that's, a constrained working environment that is not as rewarding as having time. And there's a pressure to reduce length of stay on, and mention that I worked on the Mildred Creek unit for 21 years, which was a inpatient unit for 7 to 15-year-olds with severe and complex mental health problems. We specialized in eating disorders and severe psychosomatic presentations, but we took young people with a range of complex mental health difficulties. And we did work with their families. They weren't admitted by the time I was there, and the preceding consultant, prior consultant to me, didn't admit parents, but we worked closely with families, and we very much had a systemic approach, as well as other approaches, a biopsychosocial approach, really. But one thing that was really consistent during my 21 years there was a pressure to reduce length of stay, actually. And, there were some very good papers that actually showed that sometimes longer lengths of stay did well. Green and Jacobs published an interesting paper on that and said that patients did better who had longer lengths of stay. So I was able to quote the research and talk about, that rushing patients to be discharged was not always the best thing to do. But of course, one didn't want patients to be there longer than necessary as well. But it's not just, I'm talking from my personal experience on the MCU, but in all inpatient admissions and inpatient environments in the NHS, there is this pressure to reduce length of stay. And, I'm obviously most familiar with child mental health, adult mental health, it's the same. But in other conditions and presentations as well, it's pretty similar. And staff are working very long shifts. Staff are often covering for colleagues who are off sick or vacancies. I heard recently that 1 in 3 consultant child psychiatry posts is vacant in the UK at the moment. But in different specialties, in different areas within the NHS, there's a shortage of staff, sadly, which means that those who are working are often under increased pressure. I was having a look at the 2023 NHS staff survey yesterday when I was preparing these slides. And these are some figures that it told us. 34% of all staff find their work emotionally exhausting. These staff surveys are done every year, by the way, and they're worth having a look at. They're quite interesting, and they're worth filling in. We all get, those of us working in the NHS. I've stopped working in the NHS in the last year or two, but those of us that do work in the NHS, they're worth filling in, and they're worth, giving the powers that be a sort of snapshot of how staff are feeling. 30% of staff felt burnt out because of their work, so about 1 in 3, which is quite a worrying figure. Over half of staff have gone into work in the last 3 months despite not feeling well enough to perform their duties. So that's what's known as presenteeism, going to work when you're actually unwell or not able to really work to your full potential. Absenteeism, people will know about. That's another symptom of an organisation or a staff group that are struggling, that they're not able to get into work. But I think a problem more for doctors, nurses and other health service staff is that they go in when they're actually unwell and should maybe take some days off. I worked in Australia for a year as a junior doctor, and they used to have a concept of mental health days, that if you were feeling really stressed and overloaded, you could take a mental health day, and they were very open about it. It wasn't like you had to pretend to be sick or something. You could just say, look, I'm feeling kind of overwhelmed, or I need a mental health day, and they would take a day off. And that's an interesting concept, which we might find goes against the culture in the NHS, but that's what they did in Australia. And this is not recent, believe me. It's like 30 years ago or something. So different countries and cultures do have different attitudes to these things. 41% of staff have felt unwell as a result of work-related stress. which is a concerningly high figure. And about 1 in 4 staff say that they never or rarely have unrealistic time pressures at work. So that's only 1 in 4 don't have those time pressures. So presumably 3 in 4 roughly do have these kind of unrealistic time pressures at work. I'm sure we're all very familiar with that challenge. Now, staff experience is a real driver of patient experience, and this is something, as I mentioned earlier, I've thought about a lot in my career and really felt is important. And I've often said to my trainees, make sure you take your holidays, make sure you look after yourself, make sure you get your study days. And if we look after our staff, then the staff are much more able, and if we look after ourselves, we as clinicians are much more able to look after our patients. I'm not a big fan of sort of heroism and pushing yourself to the brink kind of thing. You've got to try and keep things in proportion and, get a good night's sleep, take your days off, get your holidays, look after yourself. One of the things we had on the MCU was we had a staff group once a week where we could really talk about the challenges of our work and support each other and talk about difficulties in the work. That was not a Schwartz round, that was a team meeting, we used to call it. And that was facilitated once a month. But I've always been keen on this kind of thing, supporting staff. And I think I got that partly from my training at the Tavistock and people who came before me conveyed to me the value of that. And also one learns best from experience rather than just being told things. And we had, when I was a trainee, we had a group for the SPRs, for the senior registrars, as they were called then. And that was a very valuable group that I was part of and colleagues were part of. And we found it really a useful way of looking after ourselves during our training experience. So staff are unsupported. They're more likely to withdraw from their work for emotional protection. They're more likely to feel isolated and stressed. They have a lowered sense of personal effectiveness, so they don't have so much a sense of agency, and that is really important for well-being and health as a staff member in the NHS. That you feel you can make a difference, you feel you can change things if they need to be changed, and many people don't really feel that. Many people feel emotionally exhausted. Care can be somewhat depersonalized, and that is a sign of burnout. If you're quite burnt out as a clinician, you're not going to treat people as well as you would do if you were not burnt out yourself. So that gets back to, looking after the staff. They're then going to be better able to look after patients. There is an argument that, as doctors, we're taught to somewhat be depersonalized right from the start. So I remember as a medical student, one of my first days as a medical student, I was standing around a dead body with other medical students, and we were about to dissect this body. So there is an argument that one care is kind of depersonalized from a very early stage, but that's maybe another talk. But we want to try and go against that. And these kind of responses are likely to have a negative onward impact on the safety and quality of patient care. That was what Jill Mabon said. She's one of the primary researchers in this area in Raleigh et al. And all NHS organisations will understand, this is Bruce Keogh, who, as I recall, was a medical director of the NHS. All NHS organisations will understand the positive impact that happy and engaged staff have on patient outcomes, including mortality rates, and they'll be making this a key part of their quality improvement strategy. So this is not news. This is not a new understanding. This has been around for many years. But sometimes, putting into practice our understanding is a step too far in some organisations or in some circumstances, and that's what we need to do. We know that staff experience is a driver of patient experience, but we need to put that into practice, and Schwartz Rounds is one way of doing that. Kieran Sweeney was a GP who worked quite a bit in this area. Unfortunately, he's passed away. He died of mesothelioma, and he wrote a paper, A Patient's Journey, and he said that the health professional does a job, and for many people this job is pretty mundane, and people doing the same kind of thing to the same kind of people pretty much every day. So for them, that activity becomes somewhat routine. Now, I wouldn't describe my job like that, I have to say, but I love my job, and one of the things I love about it is that it's not mundane and not routine. But for some people, and for many people, according to Sweeney, that is their experience in the NHS. They have somewhat repetitive jobs. For the individual patient, though, Sweeney argues, it's anything but that. The individual comes, when an individual comes through a hospital, they feel apprehensive. It's probably one of their most worrying experiences of their lives. To be admitted to hospital, it's a strange place. You lie in a strange bed, you have strange sheets, you have odd tea in a plastic cup. The whole thing is vibrantly different. I remember being a patient myself a few years ago and having to have a scan and being, basically stripped pretty much naked and putting on a robe, and the robe didn't cover my back. And, I was like slightly embarrassed. And, it's sort of, you get a bit depersonalized as a patient. We need to be really careful that we don't do that to our patients any more than necessary. But anyway, Kieran Sweeney talked about his experience of being a patient, and he really wanted us to understand the importance of treating patients as human beings and understanding things from their perspective. And there's a YouTube video that you can Google it, or go to that link. We're happy to share the slides basically after this as well. So have a look at that from Kieran Sweeney. It's quite interesting. And he was one of the people that supported the development of Schwartz Rounds in the UK. So what helps? Well, interventions that aim to support staff in their work help. And ideally, these should be, this is from the King's Fund, Greenhouse. Professor Greenhouse is a professor of general practice, and she's written a lot about this, and Goodrich and Cornwell, seeing the person in the patient. The King's Fund, by the way, has a lot of useful resources on this. For those of you that don't know about it, you can Google King's Fund, and there's a wealth of material about the NHS and how the NHS works and how to look after staff in the NHS and so on. But these are interventions that have been recognised to support staff in their work. Ideally, they should be compatible with a systems perspective. So one looks at the broader system, one looks at things from a systemic perspective, not just from an individual lens. Ideally, they should be described in enough practical detail to be replicated elsewhere. You'll notice, by the way, that all the 5 of these points do apply to Schwartz Rounds. I hope that becomes clearer during the talk as well. They should be flexible so that they can be adapted to different work environments. They should be sustained or spread beyond the place where it originated, and they should be subject to an external process of assessment or evaluation. So as I say, that was not written about Schwartz Rounds. That was written about interventions that can support staff in their work. But Schwartz Rounds do cover all those bases and apply to those apply to Schwartz Rounds. So let's come on and talk about Schwartz Rounds. Enough kind of background. That photo, by the way, was taken at a Schwartz Round at the Royal Free. So those of you that know the Royal Free, they've got that big atrium near the entrance with glass doors, and that was the Schwartz Round that I went to. Not this picture wasn't taken at the run I went to particularly, but I went to one in there, and it's quite a nice environment for a Schwartz Round. So you have a panel in front, you have an audience. I'll talk about in a little while more detail about how they're set up and how they run. So Schwartz Rounds were mentioned in the Francis report from several years back as being something that can improve team building. They've been mentioned in the NHS England business plan as evidence-based initiatives that can help improve patient experience. They did begin in larger organisations. As I say, we had our first one at Great Ormond Street in 2015, but they'd been going for a few years at places like the Royal Free. I think I also went to one at UCLH before they started at Great Ormond Street. So they began in larger organisations which provided acute care, but they've now been introduced into various clinical settings. So they're in mental health trusts, they're in hospices. We've heard a lot about hospices recently with the assisted dying bill, and the need to improve hospices, and hospices are wonderful places. My father died in a Marie Curie hospice a few years ago, and it was a wonderful thing that he was able to be there actually. Primary care and educational settings. So, these are all very important clinical settings. And Schwartz Rounds are now running in more than 280 healthcare organisations across the UK and Ireland. So they're growing in number. They originated in the States, and I'll say a little bit more about that. But in the UK, they're really growing, and across the world, actually, they're in different countries. This is a slightly old slide. I couldn't find a more recent one, but this is from several years ago when there was about 200 sites. And it just gives you, the reason I left it on the slides is it just gives you an idea. As I say, there's now 280 sites, but it gives you an idea that maybe less than half are about in acute settings, such as NHS trusts, a good number in hospices, a good number in Ireland, a good number in mental health settings. But there's also some in GP practices, in community settings, in universities, some in Wales and Scotland, and there's even one in a veterinary hospital. So they can be applied in different settings. So what is a Schwartz Round? They are confidential, structured, multidisciplinary fora, and they're designed for staff to come together once a month. We used to have them once every 2 months at Great Ormond Street, but depending on what one can manage, once a month is great if you can manage it. And they're designed to reflect on the emotional and social experiences associated with their work. We had them every couple of months because we found there were a lot of work to organise, and we were all busy doing other things, and that's, as I say, what we can manage. But that was enough for them to be like 6 a year, and for them to become an important part of the sort of the work at the hospital. One important thing is that we don't seek answers at Schwartz Rounds. They're not problem solving sessions. They're not like, here's the problem, how are we going to fix it? So they're not like grand rounds where they're teaching sessions. They're not like sort of after event analysis where you think something went wrong and how are we going to try and prevent this? What went wrong? How are we going to prevent it next time? So we're not looking for answers. We're not particularly looking for expertise. There's a kind of flattened hierarchy. Everyone's voice is important. No one person is privileged over another person. So we don't look for answers. We don't look for expertise. All staff are invited, so clinical and non-clinical, and we really recognise that each individual has something to contribute. And we've had porters, we've had admin staff on the panels, and they are often the people that have the closest connection with the patients actually. And patients sometimes confide in people who are apparently so-called lower in the sort of hierarchy, as it were, but they're the people that the patients feel most able to confide in and share with, and sometimes the people who actually get to know the patients the best. And this is something that Ken Schwartz, who instigated, who was one of the pioneers of sort of the work that led on to Schwartz Rounds, I'll talk about him a bit more, but it's one of the things he said. He was someone who was dying of cancer in hospital, and he said that the sort of the domestic who came and asked him about how he was and how his family were and got to know about his children and things like that was the person who actually kind of made the most difference in terms of helping him when he was in hospital and supporting him. So all staff are very much invited, and they do follow a specified evidence-based format, which I'm going to talk more about in a minute. And the focus is not on the clinical aspects of the patients, but on the staff experience. So that is very important. Rounds can help staff feel more supported in their jobs, and they can allow them the time and space to reflect on their roles. So if you think about how often in the busy NHS week do staff stop and reflect and just give themselves time to think about their jobs, think about how they feel about their work, how they feel about particular patients or relationships. As I say, on the MCU, we used to have a staff group once a week, and we had a protected hour. Some people valued it more than others, but by and large, the staff team really valued it and saw it as an essential part of the working week. But we were a mental health unit in a ACAMH service, and that is not necessarily typical in the NHS to have that kind of protected time. And Schwartz Rounds do help to offer that to staff, to all staff within an organisation. The underlying premise for Schwartz Rounds is that the compassion shown by staff can make all the difference to a patient's experience of care. But in order to provide compassionate care, staff must themselves, in turn, feel supported in their work. And they are licensed and promoted by the Point of Care Foundation in the UK. So please Google the Point of Care Foundation. They are the organisation that oversees Schwartz Rounds in the UK. They help to train Schwartz Rounds facilitators and clinical leads within organisations. They provide a lot of resources. Some of the resources for today's presentation I got from their website and from talking to them, and I've known them for years. I'm less involved now because I'm no longer a Schwartz Round lead, but when I was working at GOSH in that role, I was linking with them quite closely, and they are the organisation that you need to link with if you're going to start running Schwartz Rounds in your organisation. So what about the origins of Schwartz Rounds? I was just talking to Arnon a little bit before the talk this afternoon about Ken Schwartz, and he heard about Ken Schwartz through his own research. But Ken was a health attorney who in 1994 was sadly diagnosed with terminal lung cancer. And during his treatment, he found that what mattered to him most as a patient were the simple acts of kindness from his caregivers. And he said that these made the unbearable bearable. So this was a relatively young man in his 50s, married with children, who was diagnosed with terminal lung cancer. He was not a smoker. He was very unlucky. But he was obviously a thoughtful, intelligent, articulate man who wanted to make things happen, even though he had a terminal illness and was overwhelmed, no doubt, with all sorts of feelings about that. And before his death, he left a legacy for the establishment of the Schwartz Center in Boston. So, as I say, they originated in the States. I did a sabbatical in the States many years ago, and I did visit some of the hospitals in North America, the pediatric hospitals, and I did talk to some colleagues about Schwartz Rounds, and some of them knew about them, some of them didn't know about them. But they spread across the States, and the idea was to help foster compassion in healthcare. And in 2009, Schwartz Rounds were brought to the UK by the Point of Care program at the King's Fund. I mentioned the King's Fund earlier. Please check it out if you don't know about it. And they continue to be implemented by the Point of Care Foundation. So at Great Ormond Street, we took about 5 or 6 years to get them going, but they were going in other organisations before that. I say we took 5 or 6 years to get them going. I mean, we were actually relatively early in implementing them, but they started in 2009 in the UK. So let me talk a bit about the format of a round, which is important because they need to be easily replicable and they need to have a clear structure. And that structure provides a kind of containment for the discussions and the emotional feelings that are brought up in Schwartz Rounds, actually, because people can be quite tearful at times. People can be quite open in a way that they might not be in other settings about how they feel about things. And we encourage that. We support that to happen if it does happen. So rounds follow a standard model to ensure that they're replicable across settings. As I've said a few times, we're aiming to look after staff, and food is an important part of looking after staff. So it's always provided at rounds. It's one of the things that when you talk to people organising Schwartz Rounds, they sometimes struggle with a little bit to get the organisation to pay for the food. And they say, oh, can't people bring their own sandwiches? And we say, no, it's an important part of it, that it's symbolic of how staff are being looked after, that we provide them with food, and we try and provide them with nice food as well, not just sort of a few packets of crisps. So food is provided. It demonstrates that the organisation values its staff and their time. It obviously encourages people to come, and that's an important symbolic way of approaching Schwartz Rounds. They normally take place once a month. They last for an hour in total. We're strict about the boundaries, that we start on time and we end on time. We don't want people to be coming and going during the round. Obviously, if people come late, we usually allow, what we did at Great Ormond Street, as I recall, is we would sort of give a 10-minute leeway. We'd often start at about 1 o'clock and we'd let people in till about 1:10, and then we'd close the door. So it was a sort of contained, safe space. And we'd ask people to switch their pages off or their mobile phones, and we wouldn't want interruptions. And if people needed to leave early, we would not particularly encourage that. We understood, though, if it was necessary, we'd ask them to sit at the back and just leave quietly. So on each panel, there should ideally be a diverse mix of clinical and non-clinical staff with different levels of seniority. So you'd have a panel of maybe 4 or 5 people, and you'd want it to be diverse, as I've just said. You'd also have a clinical lead who was often a senior doctor within the organisation, and you'd have a facilitator. So there'd be 2 people who'd done a training in facilitating and leading Schwartz Rounds. I was a clinical lead for a number of years, but one can kind of move between the roles. I also facilitated quite a few, depending who you were working with and what they preferred to do. And you would have a Schwartz Round committee that was organising Schwartz Rounds, and different members of that group would be clinical leads or facilitators. So the idea is that the presenting panel would share their experiences for 10 to 15 minutes. And by the way, a really important thing would be to prepare the presenting panel. So talk to them about what Schwartz Rounds were. Hopefully most of them had been to Schwartz Round, but sometimes they hadn't been. We, as a Schwartz Round sort of committee, would discuss every month or two who would be good on a round, who would be a good panel, who do we know within the organisation that might be willing to do this, what topics should we cover. I'll come on to topics in a little while. But preparing the panel was a really important part of what we did. So we would say to them, try not to just write something down and read it out, talk from your heart. By all means, have a few notes in front of you, but we want you to share your experience and what you want to talk about, in a kind of human being to human being kind of manner. And it's not a talk, it's not a kind of didactic presentation. It's what was your experience about whatever topic you're presenting on. And obviously we would have a theme. So the theme could be a patient or a particular clinical experience that everyone shared, or it could be something like, the doctor strikes, to strike or not to strike. I'll come on to that in a bit, the different themes that we've used. But we would get a panel together, we would meet them individually and together, ideally, depending on timings. It was always an issue about how do you get 4 panelists together in a busy hospital like Great Ormond Street for an hour before, they've already committed an hour to do the Schwartz Round. So we didn't always get the whole panel together, but we would have to be flexible about that and meet them and support them and encourage them. So trained facilitators then moderate a reflective discussion. So we would say to people, share your perspective for maybe 5 minutes. The clinical lead will have given a short introduction about Schwartz Rounds before that to the audience. And in an hour, we might have 20, 25 minutes of the panelists. It says 10 to 15 minutes there. Obviously, it's a bit variable. And then the trained facilitator would moderate a reflective discussion. And we would encourage the audience to share their thoughts, ask questions, and offer similar experiences. And that's when you knew a kind of round was going well, when someone would say, what that person said reminded me of an experience I had. And then they share a bit about their experience, and maybe they talk about something that was quite difficult for them or challenging for them. And then gradually you sort of deepen the experience and the process in the room. And some rounds are absolutely remarkable, where people really are empathizing with each other, supporting each other, and sharing things. Some people say, I'm sharing something that I've never shared with a group before. But that is not an uncommon experience, because people hopefully feel that it's a safe space, and confidentiality is really important. So we absolutely say that at the beginning of the rounds, that this is a confidential space. By all means, you can share some of the themes that came up, you can share your own experience, but please don't mention anyone's name or say that this person said that. So confidentiality is really, really key. And the discussion does not aim to problem solve or find solutions. It aims to reflect on the emotional experience of delivering care. And this can feel countercultural. It's not necessarily something that we do very well in the NHS. But I do feel, and this was one of the reasons I was really happy to devote a good chunk of my time when I was at Great Ormond Street to this, I really felt that it contributed to an improved culture within the organisation. And at Great Ormond Street, we had challenges in that area like any organisation does. And when you knew that the CEO, that the board were supportive of this, as they often were, when you knew that people valued coming to it and they were well attended, you knew that there was something kind of healthy going on in the organisation. When we had very small rounds and it was hard to get people to come and things like that, it was sometimes a little bit of a warning that, people were extremely stretched. And by and large, over the years that since we started them, they grew and they were very valued. So I mentioned topics that Schwartz Rounds that we had. Well, these are some of the possible topics. Trying to help in impossible circumstances. I mean, really, the topics are numerous. You can think of what you want in your organisation, but these are some possible topics. Conflict with a patient, with family, with colleagues. Unrewarding patients. Rewarding patients and perils associated with them. Organisational events such as a poor CQC report or a major complaint. We're human too, personal and professional overlap. A patient I'll never forget. I was actually on the panel for the first Schwartz Round at Great Ormond Street, and I talked about a patient where I made a really significant mistake with. And it was difficult to talk about. It was when I was working on a neonatal unit. I made a mistake with an injection, and I was an exhausted junior doctor. I'd been working, it happened on a Sunday at about 2 a.m, and I'd been working since the Friday morning. So, that was part of thinking about things from a systemic perspective. And next to me on the panel, and I think people appreciated, by that point I was a reasonably senior consultant, I think people appreciated seeing their seniors being honest about their mistakes and about them being human and about them feeling bad about things that have happened in their career and wishing they hadn't happened and that kind of thing. We're all human beings. Sometimes you can look at your seniors as though they're kind of, up on a pedestal and they haven't had the same experiences that you've had. But we've all had challenging experiences in our clinical careers. And next to me on that panel was the chief executive at the time, Peter Steer, who'd come over from Brisbane, Australia, to be the chief executive at Great Ormond Street. And he was a lovely man and he was very supportive, and I didn't have to persuade him too hard to be on the panel. He was willing to do it. And he talked about a patient he'll never forget when he was a junior paediatrician, also actually on the neonatal unit, and challenges that he had. And my patient didn't die, thankfully. His patient did die, and as I recall, but it was difficult experiences that we'd had in our careers that we were sharing. Those are the ones that tend to stick in your mind. And then we found that once we'd finished talking on the panel, people were sharing their experiences from the audience as well. So that was a round I'll never forget, on a patient I'll never forget. To strike or not to strike, that was a round that we did during the junior doctor strike and the consultant strike. Those are some general topics that people have done around the country, but these are some of the topics that we did at GOSH. So I've already mentioned the patient I'll never forget. Coming together in and after a crisis, reflections on 7/7. That was that terrible terrorist attack where a bus was blown up in front of the BMA building on Tavistock Square, and many patients and wounded and some unfortunately casualties, people who died. Came to Great Ormond Street, and staff from Great Ormond Street ran out because we were not that far from there. So people talked about their experiences there. 7/7. Are we really one team? Widening conversations about collaborative care. So that's one of the core values at Great Ormond Street, one team. And people do not always feel like one team. So we were able to have a kind of honest conversation about that. How does it feel when the hospital is on red? We're on red when there's kind of no bed availability, when the hospital is extremely stretched. How does that feel to people? To strike or not to strike, a modern day NHS dilemma. I've already touched on that one. There's quite strong feelings about that, a little bit like the strong feelings that are aroused by the assisted dying bill. Things can be quite polarized sometimes, and people can really feel very strongly about their perspective that it's wrong to strike, or that we have to strike to improve conditions, not just for ourselves, but for future staff. So people can feel quite strong, and, well-meaning, thoughtful, smart people can have very different views about some of these things. That's part of life. Challenges and dilemmas in working with medically unexplained symptoms. One of our staff from the MCU was on the panel for that because, as I said, we worked a lot with patients with medically unexplained symptoms. Really interesting round that was. Intensive care, reflections from critical incidents. The NHS and private medicine, are they comfortable bedfellows? That's an issue at Great Ormond Street. There's quite a big private patients wing there. And how does the NHS and the private patients wing, international private patients wing, work together? The ethics of that, and actually the private patient wing supports the NHS quite a lot by bringing in income, but people, have mixed views about that. Propping up a system under pressure, reflections from NHS staff, and also managing high-profile cases, the impact on staff. When I was at GOSH, there were quite a number of high-profile cases over the years that went to the High Court. I don't need to mention names, but people will probably remember some of these cases where, should you switch off the life support for a particular child or not, and parents really not wanting to do that, and staff saying this is the kind thing to do, and they would go to the High Court. And of course, that would be very stressful on staff. And there would be times when the hospital would be surrounded by press and TV cameras. And that particular round talked about those kind of cases. The impact on staff, and also with social media, people, naming staff, sometimes attacking staff on social media, sometimes supporting staff on social media. That's another whole topic. Maybe I'll come back to talk about social media. But that was on that round. We talked about that quite a bit. So I've already told you that we have 2 facilitators for rounds. The minimum time commitment is about 1 day a month. In reality, you don't have that in your job plan, a whole day a month, but ideally you get at least some of it in your job plan. And the facilitators prepare the panel and facilitate the rounds. And I've told you that we would make time to meet with the panelists before the round, as well as facilitate the round itself. There's a clinical lead, a role that I did for a number of years. Andrew Long did it before me, and I learnt from him. And it was great to see him at a senior level of the organisation being quite passionate and committed about supporting Schwartz Rounds, and they co-facilitate the rounds. It's important to have a good administrator. Good administrators worth their weight in gold, and they are people who make sure that the commitment, the steering group meetings, I called it a committee earlier, it's really a steering group, that they happen regularly, that people know when they are. We had them on Zoom sometimes after COVID, when everyone started to know what Zoom was, but before COVID we all would meet in person. not always easy to get everyone in the same place at the same time, but the administrator helps with that. A steering group, and we would try and meet every month if we could, about half a day a month time commitment for that. And they would attend the rounds, they would support the rounds, and people from within the steering group would think of panelists and be the facilitators or the clinical lead. And then the board, the hospital board, would need to fully support the initiative and the resource required, including providing a venue and catering. These kind of practical things, as I said, getting the food, but also getting the venue. I remember many discussions with staff at Western House and we'll know what Western House is, where they have a nice lecture theatre, but there's a lot of demands on that lecture theatre. So making sure you book it and that Schwartz Rounds are prioritised within the organisation is an important part of what we do as people organising the rounds. So I said that I'd talk a bit about the evidence. There's a couple of older studies which have shown that staff who participated in rounds, especially those who attended regularly, they report the following. These studies are, about 14 years old, but they're very good studies. Decreased feelings of stress and isolation. I'm going to talk about a more recent study in a minute as well. But if you look at the Point of Care Foundation, they have the research laid out there. I'm just giving you a bit of a flavour of it. So if you're interested in more detail about that, do go to that website. But these big studies showed that staff reported reduced feelings of stress and isolation. I've already alluded to that people hear other people describing feelings that they can identify with and relate to, and realise that they're not alone in feeling, exhausted sometimes, and feeling upset sometimes about patients. They're distressed, in feeling upset sometimes about being abused or talked to in unpleasant ways. That sometimes happens, unfortunately, as an NHS staff member. So anyway, reduced feelings of stress and isolation, feeling more valued, improved teamwork, connectedness and communication, a greater appreciation for other disciplines and roles. I would certainly say that I gained that from going to Schwartz Rounds and hearing more about other people's roles that you wouldn't necessarily hear about as much. More openness to giving and receiving support. I remember, by the way, just on that previous bullet point, I remember someone coming on a round who was in the mortuary. Now, the mortuary is literally hidden away. It's down in the basement. It's not somewhere where you visit very often, certainly not as a child psychiatrist, hopefully. Some people go there, quite often. The porters probably go there quite often, taking dead bodies, people who've passed away, to the mortuary. But anyway, I remember someone talking about his experience of working in the mortuary on a panel, and it was really interesting to appreciate this person's role and other disciplines, and just some areas, admin, being a porter, being a dietitian, being a phlebotomist, being a doctor, a nurse, a psychologist, whatever it is, we've all got important roles, and it's good to hear about other roles beyond what you do. More openness to giving and receiving support. Less hierarchies, reduced hierarchies between senior and junior staff is important. I've mentioned that's a real premise within Schwartz Rounds. Increased feelings of compassion towards patients, and increased attentiveness to social and emotional aspects of patient care. So those studies showed that in a good evidence-based way, and you can look at those studies in more detail. This is a more recent study from Jill Mabon, Dawson and others from about 3 years ago, the effectiveness of Schwartz Rounds to reduce the psychological distress of healthcare staff. And that paper reported on the implementation and evaluation of Schwartz Rounds in the UK. It said that rounds attendance was linked to a 19% reduction in psychological distress if you adjusted for covariates. People can look at this study in more detail for themselves, but really showing the benefits of Schwartz Rounds. And as an organisation-wide intervention, rounds constitute an effective, relatively low-cost intervention. We're not using much technology in Schwartz Rounds. It's basically people's time and to organise it and to attend it. But it's really a low-cost intervention to assist staff in dealing with the demands of their work and to improve their well-being. And by the way, I haven't mentioned in this talk, but post-COVID, we started doing rounds online as well. Now, we were quite sort of cautious about doing that, and we always thought it was important that they were face-to-face and in person. But we did find that Zoom rounds did actually work quite well. What we didn't do is hybrid rounds. I've found over the last few years that hybrid meetings don't often work brilliantly. Either it should be online or in person, face-to-face. Some conferences can work very well as a hybrid conference, online and in person. I've certainly seen that work well. But I think meetings like this, it's better if they're either online or in person. But so we didn't attempt a hybrid one. meeting, but we did find that the online ones work pretty well, actually, if they're carefully organized and facilitated and so on. This is a longitudinal national evaluation of Schwartz rounds, which showed that people who attended rounds, their well-being improved, and the proportion of those with psychological distress halved from sort of 25% to 12%. Again, this is another paper by Jill Mabon and others, and you can find the full evaluation on that link there. You've got to be careful about adjusting for covariates and so on. But people who didn't attend, not much change. People who did attend, significant improvement in their well-being. So, some people might be skeptical about that, but have a look at the research in more detail if you want to. And I'm not surprised by that, actually, because I think it really, you feel better when you go to Schwartz rounds, especially if you go to them regularly. You feel, as I said already, I'd be repeating myself, but less isolated, more connected with others in your organization. And these are really important things for well-being. After every round, the Point of Care Foundation and we at GOSH and at other places where they do them, we take feedback very seriously, and we really encourage people to fill in their feedback after the round. And this is, from across the country, but of over 5,000 people saying that today's round has helped them work better with their colleagues. Most people completely agreeing, or certainly agreeing somewhat. Gaining knowledge that will help them care for their patients. This is data from the Point of Care Foundation, but very, very few people disagreeing with that, and most people completely agreeing that it helps them care for patients. So what do participants say about Schwartz rounds? They say things like, I appreciate the language. You hear words used that you don't normally hear, such as anger, guilt, shame, and frustration. They're there, obviously, but there's no outlet for them. So those of us that work in mental health are a little bit maybe better at or more used to hearing these kind of words in our conversations. But even in mental health, we struggle with them sometimes. And it's good to hear this kind of language. It's good to talk about these kind of feelings that are there, but not always talked about. Someone else said, there's always hierarchy in a hospital, but in a room like that, you are all carers in a caring environment. Your opinion is always listened to. By the way, I'm remembering Schwartz rounds as I give this talk, but I'm conscious that many of you have never attended them. So I would really encourage you to attend them if you can, or introduce them into your organization if you can. But one way of getting a flavor of them, if you haven't had an experience of them, is to go to the Point of Care website, and there's a video of a Schwartz round there. So you can, do check that out. In the context of mid-staffs, people will probably remember that pretty well. It's quite a few years ago now. Staff are expressing things, and the rounds are a sign that it's safe to speak. It's all very well to say we have an open culture, but this demonstrates that value. Someone else said nursing staff, physios, all staff really say they have a greater sympathy for doctors who seem less cold and hard. And doctors have a greater respect for the rest of the team as they appreciate what they do and what they're having to take home with them. So that's really important, and it's so basic. We as doctors, we're not all doctors on this call, I'm sure, but we know that we're human beings, but we sometimes get seen as kind of cold and distant by other people. We sometimes present as that for our own reasons, and it's really important that we as doctors have greater respect for the rest of the team and recognize their roles and vice versa. So that's something that Schwartz round can contribute to and help with. And the rounds are not linked to targets. It counterbalances some of the target stuff and humanizes the mix, someone said. So, that's really important. And rounds can start going in that direction, and it's a little bit of a defensive maneuver in a large group if it starts getting a bit uncomfortable and people are talking about things like anger and guilt, for someone to get into like problem solving and well, I wouldn't have done it that way, I would have done it this way. And that's not really what Schwartz rounds are about. It's not at all what Schwartz rounds are about. So we're not aiming at fixing things or what we should have done. We're aiming at emotional expression, people feeling supported, people expressing how they feel in their role as a healthcare deliverer. Our feedback at Great Ormond Street was largely positive. This is the kind of thing that people said, that it was interesting, informative, insightful, moving and emotive, thought-provoking. Think about how one is affected by one's work, as well as making you think about how other people are affected in the hospital, for example, non-clinical people. So that I just want to reiterate that it's not just for clinicians, it's people from at all levels and all different roles within the organization. And I really enjoyed it when, for example, porters and administrators came to the rounds and shared how they felt about their roles. These are some other themes. This is looking at the feedback that we got at Great Ormond Street. A process that embodies openness, a culture of being open, a process that encourages connection, that invites appreciation and invites reflection. What makes for a good round? Well, connecting with emotion, having a mix of people, having a good turnout, obviously, having a good panel, being well facilitated, having a good discussion and a good facilitator, and a process that highlights the need for more staff support. So I'm doing okay for timing. I wanted to finish within an hour. So rounds offer a safe, reflective space for staff to share stories with their peers about their work and its impact on them. This is sort of one of the concluding statements I want to make. Attendance is associated with a statistically significant improvement in staff psychological well-being, and I've shown you some of the studies, but I've sort of skirted over them in a little, not in huge detail, but you can look at them in more detail if you want to on the Point of Care Foundation website and elsewhere. And the reported outcomes do include increased empathy and compassion for patients and colleagues and positive changes in practice. So if you want to introduce Schwartz Rounds, and I'd be really keen that you do if you haven't got them in your organization, go to the Point of Care Foundation website, download an information pack, contact them. You'll find the staff there very friendly and keen to talk to you about it. And you can arrange to observe a round. By the way, we also had mentors, so someone more senior within the organization and someone who's more experienced than you are as a new facilitator or as a new clinical lead. You can have a mentor. They will come to your round, they will observe it, they'll give you feedback afterwards. We always debriefed rounds as well, by the way. So after the hour-long round, we would stay for 15 or 20 minutes afterwards, time permitting, and we would debrief with the panel and with the facilitator and the clinical lead. And the mentor would come to that sometimes as well. They might have been in the audience and they'd contribute at that point. So you need to identify a facilitator, a clinical lead, and an administrator. You need to identify members of the steering group. These are sort of single bullet points, but believe me, they're not straightforward to get like 10 busy people together for a steering group. But, word of mouth, thinking about who you think might be suitable and might be agreeable, getting people, you need to start somewhere. And I often have that analogy in my head about, a pool, and you throw a little stone into the pool and it has ripples. And so small things can lead to bigger things, and changing culture within organizations. So you've got to start somewhere. So I would really encourage those of you who would like to start Schwartz Rounds in your organizations. Get board support. That's really important as well. Talk to the CEO or the medical director or the head of nursing or whoever who's on the board. Help them. They need to sign a contract. They need to pay for support from the Point of Care Foundation. You've got to go to training. That's a couple of days. It's in two parts. So I did a training a long time ago. I think it's like 2 days and then another day at a later stage. But it's a really fun day. And there's also an annual conference for people that are involved in steering groups and meet people from all around the country that work in this area. Sort of annual conference. I haven't been to that for a little while. But giving this talk is reminding me of those sort of things that I was more involved with when I was at Great Ormond Street. So I'd like to encourage you to get more involved. And only organisations supported by the Point of Care Foundation are authorised to run Schwartz Rounds. So you can't just, copycat them and go and do them in your organisation. They need to be properly facilitated and supported by the resources of the Point of Care Foundation. So those are some contact details. I'd be more than happy to be emailed if people want to email me a bit more about it. That's my X handle. I've actually moved over to Blue Sky. That's another whole conversation, but I decided I didn't want to be as much in a social media group led by Elon Musk. I won't get into that too much now, but that is my X handle, and you can also find me on Blue Sky. Point of Care Foundation, they are now on Blue Sky as well as X. There's their website. That's my website as well if you want to find out a bit more about me. But thanks for listening. I'd really encourage you to go to the Point of Care Foundation website and check it out, and you'll learn more about Schwartz Rounds. But I really appreciate those of you that have joined us. It's nice to talk about Schwartz Rounds again. I haven't thought about them for a little while, so it's nice to have a reason to do that again. And now we've got a bit of time to, I'm going to stop sharing my slides. and hopefully we've got some questions. And please do, it looks like we haven't got many yet, but please do put some questions in the Q&A, and we're more than happy to hear from you and have a bit of a discussion. Over to you, Arnie.
Thank you, John. Brilliant presentation. David Trickey from the Anna Freud echoes, thank you for this brilliant presentation. And he asks, how much would be lost by doing rounds remotely? Would it still be worth doing? And has there been any research into the economic benefits, which I think is a very interesting aspect of it. Thank you, David.
Yeah, nice to hear from you, David, a former colleague from Great Ormond Street many years ago.
Right.
So yeah, I did touch on it a little bit about the remote rounds. I was a bit surprised, that they worked as well as they did. I've been a bit surprised about that in my clinical practice as well, one-to-one or with patients or, with patients and their families. I do a good chunk of my practice now online, and it works. People are getting used to it. We're much more used to it than we were pre-COVID, obviously. Young people are very used to working, via screens, and so are increasingly adults in their work settings and so on, doing more and more meetings remotely. So the answer is it does work. It does depend how it's handled. Obviously, you don't want to have a Schwartz round where everyone has their cameras off. I think that's a bit off-putting for the panel. So you really want to encourage people to put their cameras on as much as possible. We do recognise that people might have children running around in the background, or they might want to be eating and not have their cameras on. But by and large, try and have a good percentage of people with their cameras on so that the panelists can see who they're talking to. And yeah, they work okay. And we, post-COVID, we had a mixture of them. So we did some remotely via Zoom, and we did some face-to-face. But as I say, as someone who's facilitated quite a lot of these in different settings, not just Schwartz rounds, it's quite hard to facilitate a group like this that is a hybrid, because what you find is that everyone who's there face to face looks at the screen, and then, one person on the screen becomes a bit like Big Brother, and you're all paying attention to them, and then the dynamics within the room face to face get a little bit neglected. So, or you find that everyone who's online is talking to each other and people are being quiet in the room, or everyone in the room is talking and everyone online is quiet. So the hybrid ones for this kind of meeting, a facilitated group discussion, a bar-link group or Schwartz round. Bar-link groups are quite different to Schwartz rounds, by the way. I could touch on the difference between them. Bar-link groups, they're people talk about particular patients from their own perspective, but they are, they have a facilitator in the room. It's a group that meets every week or every month with a defined number of people. The group gets to know each other. A Schwartz round is a much larger group, and people go there who don't necessarily know each other, but they do find a kind of connection, which is possible to achieve via Zoom as well as in person. I have to confess to a preference for the face-to-face Schwartz round, but they do work fine online as well.
Thanks. And David's got a follow-up question. Do you have any tips for fitting rounds in around shift working? He worries that they would be seen as too difficult to make staff available and still run a ward. And if I could ask a supplement to that question from David, I've been trying to get my head round an organization like Great Ormond Street with these super specialist units, which are, as you say, know everything about particular sort of organ systems and integrating very, very significant number of folks. And I was just sort of thinking, you'd almost need a dozen Schwartz rounds going on in parallel if you were really to try to make it possible for an organization with a tremendous number of folk. I mean, just thinking of the psychological medicine, large enough, but if you include the medicines and if you include the endocrinologies and you've got that cardiac team and so on, I mean, how can one differ? I mean, it's interesting, you started with the Royal Free, which of course has got a much smaller child health component, but on the other hand has a much larger medical component. But in terms of the size of the organization, how does it work, both David's point really about how to manage around the shift issues in terms of staffing and balancing the work and so on. Some of those practical issues.
Yeah. So we thought about this. It's a good question, David. We thought about this quite a lot in terms of what time should we have the round, and we tended to try and move it a little bit. So sometimes we would have an early round to try and get people who were, on early shifts kind of routinely. We might have a breakfast round sometimes. We experimented a little bit with this exact question. Sometimes we would have an end of day round. What worked best was a lunchtime round, but we found that nurses found it harder to come to a lunchtime round because they were often doing their handovers around lunchtime from the morning shift to the afternoon shift. So there's no ideal solution about timings, but I did say it's important to be as diverse as possible, inclusive as possible. So the way we managed it was to offer rounds at different times. But we tended to get the best attendance at lunchtime rounds, so that's what we that's what we tended to have more of. Your point, Arnon, about reaching everyone. I mean, I made the point earlier about, putting a rock in or a stone in a pool and ripples. I think, you might get 50 people, you might get 100 people. If it's a small round, you might get 20 or 30 people attending. But they do go and talk to their colleagues about it, hopefully. And I think it does change the culture in the organisation, having Schwartz rounds within an organisation like Great Ormond Street. And you have to be realistic. I mean, you can't have a whole number of parallel Schwartz rounds happening all at once a month is ideal. We were realistic about what we could manage, and we had them every 2 months. If you can have them monthly, that's a preferable thing. You can have 150 people at a Schwartz round, so we hated turning people around. It obviously depends on the size of the room. We did have one or two rounds when the CEO is on the panel, when it's an early one, that kind of thing. They tend to be better attended sometimes. So we did have rounds that were, up to 150 people squashed into a room, standing room only. One of that first round that I was on the panel for, and the CEO was on the panel for. People were very interested in it, and we did have a lot of people attending. But when it's on Zoom or remotely, it's kind of unlimited, isn't it? You can have as many as are able to come. So I think you have to, do what you can manage. I always used to like it as well when, someone was on the panel who was a surgeon or, an orthopedic surgeon or the medic, to have a medical director who was not in a mental health specialty, very involved and supporting it. Because, I think within mental health, we're more familiar with this kind of approach and round, not always, but more so than perhaps in orthopedic surgery, to take a different extreme example. But it was great. I loved it when you did have someone on the panel who was not particularly familiar with this approach and found it really useful and was able to say, this operation went wrong and I felt really lousy about it, and was able to share their experiences. And for junior surgeons, for example, to see a senior surgeon talking like that can be really, career enhancing, life changing. To feel like you're not alone, and you're not completely on a pedestal and untouchable, and you are a human being in whatever role you're in within healthcare. So I wouldn't underestimate the impact of even smaller rounds or having them less frequently. Ideally, it's one of my motivations for giving this talk and supporting the Point of Care Foundation and other organisation, really wanting to encourage those of you to run these rounds yourself. Ideally, they will spread and will grow, and they have done, but we'd like to see more of them around, definitely.
The other interesting point that occurred to me, I mean, both of us have links with another institution in North London, which has been subject to enormous conflict and difficulties around the GIDS problem. I just wonder whether a problem like that, which has such an enormous impact across the whole of an organization, whether something like a Schwartz round might help in terms where there is really very significant issues of conflict which are emerging around a particular issue. I mean, certainly they occur perhaps not quite to the same extent, but I have a recollection at Great Ormond Street of a tremendous controversy around the issue of surveillance, because the idea of surveying where there's a concern whether a parent might be harming a child, and a lot of controversy about whether it's ethical to have surveillance and so on. But in an organization where there is a major conflict around particular issues, such as we all have all learnt far too much of in the public discourse, so this is not a private matter. Do you think that the sort of notion of a Schwartz round could really begin to move the whole of an organization forwards? And not sure, that may be quite a controversial issue, but it's an important one in terms of our conflictual context that we sometimes work in.
Yeah. It's a good question, and I think Schwartz rounds, as I've said a couple of times, really can shift the culture of an organization. So I think, you were referring to the Tavistock, and GIDS, for the people that don't know what that stands for, is the Gender Identity Disorder Service. So I'm sure people are familiar with what Anna's talking about in terms of the controversies there. And that's a national and international controversy as well. It goes way beyond the Tavistock. But, I think Schwartz rounds contribute to a more caring, connected, supportive environment within a staff group. So when you do have these kind of controversies that you've suggested and talked about, Arnon, people can hopefully support each other better within that organization. If there's a kind of culture that, you don't suffer in silence, you're not alone, people can talk to each other about difficult things. What I wouldn't do is sort of wheel in a Schwartz round to a really hot issue that, and we did face this at Great Ormond Street sometimes. There was the Charlie Gard incident and Charlie Gard business and other things. I remember what you're talking about video surveillance and things like that. That was a bit before my time, but I there were echoes of it in subsequent years. And these controversial topics, a Schwartz round is not about problem solving. It's not about, this is a difficulty, let's get a Schwartz round to sort it out. That is not what Schwartz rounds are about. They're about creating a climate and an atmosphere and an environment for people to talk about what's on their mind and share their emotional feelings about, working within healthcare. So we don't want them to be hijacked in that kind of way. We did sometimes do very small rounds within wards at Great Ormond Street that were kind of based on Schwartz round, but we didn't say they were Schwartz round. They were more like, people would say, we've got a problem in our ward, can you come and do a Schwartz round? And we'd say, well, no, that's not quite a Schwartz round. We're willing to come and facilitate a discussion about this particular topic, but it's not going to be a Schwartz round, because you don't want to have that goal for a Schwartz round, otherwise it doesn't work as well, basically. So by all means have, when you've got a hot issue going on, by all means get the team together, get it facilitated, encourage people to talk to each other. When it was an issue at Great Ormond Street, I can talk from that experience, that was a really hot issue. We wouldn't have a Schwartz round on it by and large. We would wait several months. We'd wait for the organisation to deal with the strike, to deal with the controversies around, fabricated illness and how you managed a particular patient, to deal with, the issues around end-of-life care for a particular patient that were making the media. We wouldn't have a Schwartz round at that time about it. We might have one 6 to 12 months later when the dust had settled, when the organisation had addressed that issue in a more formal way, and then we would have maybe a Schwartz round about it. So I hope that kind of answers your question.
Well, that's very interesting. I suppose the other point that comes to mind, one of the characteristics of ACAMH is that we've got practitioners from across the field of social care education. And you mentioned that there were some developments outside healthcare.
Yeah.
And obviously one wonders within and the parallels within compassionate views about education. And we have and in January, early morning, we have a very interesting presentation from Australia, from Brisbane, about the development of compassionate educational contexts across educational settings and the need for that, and the characteristic of burnout that you described, which is so characteristic when individuals don't have the support. And I just wonder whether the model has application within healthcare, within social care, within many of the organizations which was so much in the news about the conflicts and difficulties. And I just wonder whether this model has really got a major application across services.
Well, another good question, and I think it is increasingly starting to be applied in other settings. As I say, there's hospices is one area. community teams, but also schools. And I facilitated a group in a prison for a year when I was a trainee, and that was one of the things that kind of got me interested in facilitated groups. So, the kind of approach of getting people together and having a protected space and having time to sort of to think with your colleagues about the work is important. I mean, Schwartz Rounds is a very specific approach, and I've sort of outlined how it works and the format and what it is and what it isn't. It's not a problem-solving forum. It's a space to reflect and share and connect. But yeah, I mean, absolutely, you could do that in schools. I'm reminded of when I did my elective in child psychiatry in Canada many years ago, going as a sort of medical student to a school with a more senior doctor. And what we did is we went into a classroom of teenagers, and it was like the health education kind of class, and people could ask any questions they wanted, and they'd write it on a piece of paper and pass it to the front, and we'd read out these questions. The reason I sort of remember that is just, that within education settings, people are hungry for spaces where they can talk about whatever's on their mind, whatever they might need help with, spaces where it's emotionally safe, where it's protected, where the people running them are trusted to contain whatever comes up, and that people can kind of share their common humanity, really. So absolutely, Schwartz rounds can be run in educational settings, and that's starting to happen, but they're more, traditionally associated with healthcare environments, partly because of how they started with Ken Schwartz in a hospital, but it's broadening out, and I'd be very keen that they broaden out further. And I know from working with teachers and, having many of my patients, or practically all my patients in schools, and children myself who've been through the education system, there's the strains that, school environments can offer for teachers, and the importance of looking after them as teachers and their well-being in order for them to be good educationalists and so on. So I would be all in favor of that happening more. And there certainly is the potential for that to happen more in the future.
Thank you. And one of the questioners reflected very much the same point. Does research evidence that impact in regard to improvement in psychological well-being in similar organizations that hold rounds outside of hospital settings, social care and education? So participant asking basically the same question that I've raised.
Yeah, and check out, as I say, the Point of Care Foundation for the research, the most up-to-date research and the resources that are there. And because there's few organizations that have run them, in educational settings, obviously they're contributing to the research less. But I think that will happen more in the future. And the findings that I've put forward recently, earlier in the talk, were from studies that applied to education settings, some of them as well as healthcare settings. So yeah, I think it's transferable, really.
Yes, it's interesting, as you say, that they've developed in a health setting, but I think it's become more and more evident that there is a need across services for approaches of this nature to really help manage, because we have tremendous problems with individuals who are not able to work because of health issues. And
Yeah,
if,
yeah.
in fact, within and the stories of what was happening over COVID in hospitals and the stress on staff, the need for support, the need for a capacity to share in this way is so striking, isn't it? I think.
Absolutely. And it was brought home to me, as I say, on an early in my career as a trainee working in a prison. The staff there were under huge stress and really did not have an outlet for it. And they really attended that group very well because it was so desperately needed. Now, that was before I'd even heard of Schwartz Rounds, but there's obviously overlap between Schwartz Rounds and other kind of facilitated staff groups. So, both are important.
Absolutely. I mean, it's interesting. I was very much put in mind to one of my most valued experiences in my early training. I was a trainee at the Maudsley in my first 6 months, and sadly, one of my patients suicided and was found in the grounds of the hospital, which, as you can imagine, for a new trainee just starting out in this field
Absolutely.
was very traumatic. But we were fortunate that Dr. Robert Hobson,
Mm.
had a meeting where we were all able to share our feelings and experiences of this of this event, which had an enormous healing, supportive, and helpful effect. So there's no doubt that the approach that you're describing has enormous value and in a way taps into the best of what we do in our professions, and so important. And one of the privileges, I think, working in a hospital like Great Ormond Street is to work with such a great range of colleagues in so many different contexts. There's so much experience to share and to support. So it's a very valuable approach, I think, that's been developed in recent years.
Yeah, yeah. And it is interesting how these approaches echo through the generations. I smiled when you said Bob Hobson. That was in Manchester. I don't know if that was in Manchester when you were.
It was in the Maudsley. No,
at the Maudsley. Okay, so he was there.
He went to Manchester after. Yeah.
So when I was a medical student, he was an influence on me.
Yes,
and I was in groups with him as well. So these people echo through the generations, and
absolutely,
it must have been a good group at the Maudsley. Yeah.
Right. Well, look, folks, I think it seems that we haven't any questions. I've run through the issues which you've raised for me, which have been extremely interesting. So I think we should finish at this point.
Sure.
And I think that ACAMH is going to ask participants to give some feedback. But I know that people will be very interested to have the opportunity of being able to see the presentation and think about it. And again, certainly look forward to the development and further development of this really excellent approach. So thank you very much indeed.
Thank you for inviting me on. Thank you. And thank you to the audience for coming. Thank you.
Thank you.
Find out more about becoming an ACAMH member and to be part of the advancement of child and adolescent mental health. Visit www.acamh.org.